Good afternoon and welcome to today's webinar on current and future applications of 3D printing in orthotics, restorative, and regenerative dentistry. I'm Dan Lemire, the Executive Director of the Society for Biomaterials. Before we get started, if you have any questions, please type them into the questions pane, and we'll do our best to address them with each speaker at the end of their presentations. A recording of today's webinar will be available on the SFB website in the next few days. Please allow me to introduce Daniel Harrington. Dr. Harrington is currently an assistant professor in the Department of Diagnostics and Biomedical Sciences at the University of Texas Health Science Center in Houston, holds an adjunct appointments at nearby Rice University, and serves as a senior scientist in the Houston Center for Biomaterials and Biomimetics. His research involves 3D cultures and matrices for both regenerative medicine and lab-on-a-chip applications. He currently serves as the Secretary-Treasurer for the Dental Craniofacial Biomaterials SIG and industry representative for the Engineered Cells and Tissue Microenvironment SIG in the Society for Biomaterials. Dan, take it away. You are muted, sir.
Of course I am, because that's the way these work these days. Apologies. I said good morning or good afternoon to wherever you're joining us for today's webinar. Thanks for the introduction, Dan. It's a pleasure to introduce both of our speakers. We'll start with our first one. And especially because Kurt Casper is a colleague of mine at the University of Texas Health Science Center at Houston. He holds an appointment there as associate professor in the Department of Orthodontics. Kurt's research applies fundamentals of engineering, material science, and the biosciences towards the development and evaluation of biomaterials-based technologies to meet clinical needs. Dr. Casper has enjoyed membership in the Society for Biomaterials for over 15 years. He received the Young Investigator Award in 2013, and he's presently the chair of the Dental Craniofacial Biomaterials SIG in the SFB. He's my colleague, and I'm really thrilled to hear his talk today. So, Kurt, please go right ahead.
Dan, thank you so much for the kind introduction, and hello everyone. Thanks for joining us today. Let me see if I can show my screen here. I hope that that is projecting.
Looks good, Kurt, thanks.
Okay, very good. Well, I'd like to share the next few minutes talking about some current and emerging applications of 3D printing in the field of orthodontics, with a particular focus on the digital workflow and how that digital workflow is being applied in clear aligner therapy in orthodontics. I'll begin by just stating that I don't have any disclosures related to this presentation. And I'd like to begin the talk with a primer on orthodontics and orthodontic tooth movement. So in a nutshell, orthodontics is seeking to correct malocclusion that's arising from a skeletal discrepancy or a dental discrepancy or a combination of the two. And often that involves orthodontic tooth movement. So movement of the teeth in the jaws. And that is accomplished through application of an orthodontic force to the teeth. And that force provides a compression in the periodontal ligament space on one side of the tooth that results in bone resorption. At the same time, it results in tension in the periodontal ligament space on the other side of the tooth that recruits osteoblasts and results in bone formation. So through this resorption and deposition of bone on either side of a tooth, the tooth in question will move through the alveolar housing as a result of the application of this orthodontic force. And the orthodontic forces have traditionally been applied to teeth through orthodontic brackets or braces like we see in this cartoon here. And in the next slide, we see photographs of various iterations of orthodontic brackets. Many of us are familiar with the traditional metal brackets, but over the years, aesthetic alternatives to metal brackets such as plastic and ceramic brackets have emerged in the orthodontic space to provide an aesthetic alternative that many patients, especially adult patients, like to have in their treatment planning. But of course, in the past couple of decades, there's been the emergence of clear aligner therapies, as we see in this bottom left photo. So the clear aligner therapies involve a thermoformed thin film of plastic that wraps around the teeth, and it's this plastic that can be used to apply orthodontic forces to the tooth, and that's a very popular option in treatment, especially among adult patients these days. But really, the vision for clear aligner therapy began in the 1950s with a doctor named Dr. Harold Kessling, who was taking plaster models of patients' teeth, isolating teeth from the model with a little saw, and then sequentially manipulating the positions of the teeth from where they were at the beginning when the patient presented to where the doctor would want them to be at the final stages of treatment, and then making, in this case, a vulcanized rubber appliance on this plaster model for each step of tooth movement. And although that appeared to be an effective way of moving teeth at the time, Dr. Kessling reported in one of his manuscripts that it just wasn't a practical workflow because it was too laborious. But that thought was kind of placed on the shelf for several decades and reemerged with the emergence of digital scanning technologies and 3D printing technologies in the later part of the 1900s. And so really these digital tools have enabled the resurgence of this aligner therapy and have enabled clear aligner therapies to really take a large market share in the past couple of decades. So just to give you a brief introduction to digital scanning technologies, one can still apply traditional impression techniques using alginate or polyvinyl siloxane to capture the dental anatomy of a patient and then cast a plaster or stone model from that impression. That stone model can then be placed in a desktop scanner, such as we see on this slide, that uses light to register the surface of that model, and that results in a digital rendering of the dental anatomy of the patient. That digital rendering can then be used in software to allow for digital manipulation of the positions of the teeth, as opposed to the physical manipulation of the positions of the teeth in the model as Dr. Kessling had done in the last century. Of course, in recent years, there has been the widespread application of intraoral scanners in dental clinics. And these intraoral scanners involve wands that are moved throughout the mouth of the patient and allow for capture of the dental anatomy of the patient directly without the need for a physical impression of the patient's teeth. And there are a number of advantages for these directly captured intraoral scans, including that they require less storage than stone models. There's a minimal risk of breakage, and they can be easily duplicated and shared with laboratories and other clinicians. When we think about the workflow in digital dentistry and digital orthodontics, this workflow can be boiled down to three principal components in my view. And the first step is image acquisition. And in clear aligner therapy, that would involve scanning, be it scanning of a cast model from an impression that was physically taken of the patient's dentition or a directly captured intraoral scan. That digital scan of the patient's anatomy is then manipulated as needed to affect the treatment of the patient. And then parts are designed. And we'll see how there are different workflows that can be applied in clear aligner therapy to either design models that correspond to steps of tooth movement, or potentially to design appliances directly that could be manufactured to affect tooth movement. But regardless of what is designed digitally, there needs to be some way to produce a tangible part that can be used to affect patient care. And that's where 3D printing comes into play. So these digitally designed models or parts can then be brought into the real world through 3D printing technologies that take the digital design into a tangible part. In the clear aligner therapy workflow, the traditional method has involved getting the digital model of the patient's anatomy by whichever pathway is best for the clinician, manipulating the positions of the teeth digitally, and then 3D printing a series of models of the teeth that correspond to the iterative steps of tooth movement. So one can move a tooth only a certain amount at a given time. So it would take maybe 30 or 40 steps to move a tooth from where it's beginning to where one would want it to ideally end up for a patient. So then those 3D printed models serve as the foundation for thermoforming appliances that serve as the clear aligners. So a sheet of the thermoforming plastic is thermoformed onto that model, and then it's trimmed and delivered to the patient. So we'll talk about 3D printing applications in that workflow, but we'll also talk at the latter portion of our time together today on an emerging alternative workflow, which would involve the digital design of the aligners themselves and then 3D printing the aligners directly, which would obviate the need to 3D print the models and thermoform aligners on those models. In either case, there are various aspects of the 3D printing process or technology that can affect the dimensional fidelity and potential clinical utility of the parts or models that are produced using the technology. And although there are a bunch of different flavors of 3D printing technologies used in the orthodontic and dental spaces, a stereolithography is a dominant player in the dental space presently, and all 3D printing formats are going to involve building a three-dimensional part layer by layer, where sequential layers attach to layers that have been printed previous to the layer that's being printed at a given time. So I'll discuss a few studies from our laboratory where we've investigated the dimensional fidelity of parts that have been produced by 3D printing for clear aligner therapies. And the bulk of this work has involved scanning of the surfaces of the 3D printed parts and then comparing the surface of the part that was printed to the surface of the digitally planned part using metrology software, which enables us to quantify dimensional deviations in location-specific fashion for these 3D printed parts. One of our first studies in this space, which was reported in the American Journal of Orthodontics and Dentofacial Orthopedics in 2017, investigated the effect of print layer height on dimensional deviation of 3D printed dental models. So in this case, we changed the thickness of the layers of material that were being printed at any given time from 25 microns to 50 microns to 100 microns and printed models at each of these layer heights and compared the dimensional deviations. We found that there were statistically significant differences in the dimensional deviations of the models that were printed at each of the layer heights, with the thinner layer heights presenting significantly greater dimensional deviation in absolute terms on the order of about 85 microns, with the 100 micron layer height presenting statistically significantly less dimensional deviation on the order of about 65 microns, which was the opposite trend of what we were anticipating. But we anticipate that part of the underlying reason is a propagation of error over the larger number of layers that are needed to print a given part at the thinner layer height. So using a thinner layer height of 25 microns, it might take 16 layers, for example, to print a part that would take only 4 layers at 100 microns. And as one propagates the error associated with printing any given layer across 4 times as many layers in printing at the thinner layer height, then one could potentially result in a model with greater dimensional deviations. And it's important to note that dimensional deviation is distinct from the surface smoothness or surface features, the quality of the surface of the 3D printed part, and perhaps that's something that we could get into in questions and answers. We also investigated the effect of the print orientation on the dimensional accuracy of 3D printed models, and this has an impact on the efficiency of the workflow in printing models for clear aligner therapy. So one can use any number of different orientations. The 3 that were investigated are shown in this slide. One could print the models flat on the build platform, but if one does that, one can only fit a certain number of models on the build platform at any given time. If one were to orient the models perpendicular with respect to the build platform, however, one could potentially fit many more models on the build platform for a given print run and thereby increase the efficiency of the production workflow. So we applied the same metrology tools, and we found that in this particular case, the perpendicularly oriented models presented with greater absolute deviation, so greater dimensional deviation compared to the flat and a 20-degree offset orientation, which were not statistically significantly different from each other. But all three groups presented overall deviations that were less than 0.2 of a millimeter on average. And that is within what has been reported to be a clinically acceptable tolerance limit for many orthodontic applications. When we looked at the superimposition maps to see where the dimensional deviations were occurring, we see in the perpendicularly oriented part, for example, underbuilding of the model in dark blue colors and overbuilding of the model in warmer colors, the red and orange. And we see that there is characteristic underbuilding in the anterior dentition, so these incisors, and on the most distal aspect of the most posterior tooth, in this case, the second molar, that back portion of the second molar was underbuilt. And we could attribute that to the 3D printing process. For example, error propagation could lead to underbuilding of the part in these final layers that are printed, so the layers that are furthest away from the build platform for the perpendicular orientation. And we could also attribute the underbuilding on the distal aspect of those second molars to unsupported regions of the second molars that were printed but didn't incorporate into the 3D printed part, which would manifest as an underbuilding in those regions that didn't incorporate into the part. So clearly there are significant effects of tunable aspects of the 3D printing process, such as the layer height that one chooses to print their models, or the orientation at which one desires to print their models, on the dimensional fidelity of the models that are produced. And again, just as a reminder, these 3D printed models would serve as the foundation for a fabrication of a clear aligner with a thermoforming process in the traditional clear aligner therapy workflow. But we have been interested in recent years in exploring an alternative workflow where the aligners could be digitally designed and then the aligners could be 3D printed in a material that's appropriate for long-term intraoral application. And we've been investigating some of the aspects, the effects of tunable aspects of the 3D printing process on this workflow for clear aligner fabrication. And I'll highlight just two brief examples. One is looking at the effect of the orientation of the clear aligner, which in this case has a shell-like morphology as opposed to a solid dental model that we saw before, on the dimensional fidelity of that 3D printed aligner. And we found when we compared 45-degree offset, a horizontal orientation, or a vertical or perpendicular orientation, that there was no statistically significant effect of the orientation on positive or negative deviation, or the percentage of points out of 1/4 of a millimeter tolerance. But we did see that there was a statistically significantly lower mean standard deviation for the 45-degree group, indicating that there was less spread in the deviations for the 45-degree group than the other groups investigated. But again, it's important to note that none of the deviations that were observed exceeded the 250 micron tolerance threshold that's been reported in the literature for orthodontic applications on average. When we look at where the deviations were occurring, we could see that there are characteristic patterns depending on the orientation that was explored. But given the limited amount of time, I would just highlight that there was overbuilding that was observed, as shown by warm colors, on the intaglio surface. So this would be the tooth contacting surface of each of the aligners. So although the average deviations were within clinically acceptable tolerances, one can see that there are deviations in the tooth contacting surface that may affect the ability of this aligner to seat on the patient's teeth, so it may not fit. If it does fit, it may be applying undesired orthodontic forces onto those teeth. And another study, we investigated the impact of the post-print UV curing duration on the dimensional fidelity, looking at the manufacturer's recommended curing duration of 20 minutes in this particular case, double that duration, and then with no post-print UV curing. And we found that there was no statistically significant difference in mean positive or negative deviation or the percentage of points out of a clinically acceptable tolerance range. but we did see that there was a significant difference in the mean standard deviation, with the 40 minutes treatment group having significantly less standard deviation, so less spread in the deviation data. You might notice that the no cure group results are not presented here, and that's because those aligners were so floppy or flexible that they couldn't be accommodated in the scanner for 8 out of the 10 samples. And here, as we saw before, there is overbuilding of the parts in each group on the intaglio or tooth contacting surface, which could have an impact on the clinical utility of these parts in terms of their fit on the teeth and the orthodontic tooth movement that they could affect. So we've seen in printing tunable aspects of the 3D printing process can affect the dimensional fidelity of 3D printed models that can be used to fabricate clear aligners through a traditional workflow. We've also seen how tunable aspects of the 3D printing process can affect the dimensional fidelity of appliances that are fabricated directly by 3D printing. And I'll just wrap up by stating briefly that we're exploring how 3D printing technologies can be applied to sequentially move the cleft segments of the alveolar segments of cleft lip and palate patients in their very early stages of infancy, using a 3D printed appliance that could direct the movement of the cleft alveolar segments closer together iteratively before a surgical repair is done. So by applying a sequence of these nasoalveolar molding appliances like we see here, one could sequentially move these cleft alveolar segments together as analogous to how one is moving teeth sequentially in clear aligner therapy. And in these nasoalveolar molding applications, this cleft space could be sequentially reduced to minimize the amount of space that has to be reduced in a surgical repair of the cleft for these patients. So in summary, digital imaging and 3D printing have enabled new workflows in dentistry, especially as related to clear aligner therapies. And as the landscape of materials appropriate for intraoral applications expands, so too do the clinical applications of 3D printing, especially of directly fabricated appliances when those appliances are made directly by 3D printing. But in any case, one should investigate the effects of tunable aspects of the 3D printing process on the dimensional fidelity and potential clinical utility of the parts that are being produced by 3D printing. So I'll just end with some acknowledgements, and that wraps up my presentation. Thank you very much for your participation this afternoon, and I look forward to some discussion at the end of the hour.
Thanks so much, Kurt. That's really, it's always exciting to hear about the newest things coming out of that kind of technology. So thanks so much. We'll entertain questions at the end of the two presentations for both speakers. So it's my pleasure now to introduce our second speaker. Dr. Luis Bertazzoni is an associate professor at Oregon Health and Science University. He holds appointments at the Department of Restorative Dentistry, the OHSU Center for Regenerative Medicine, the Department of Biomedical Engineering, and the Cancer Early Detection Advanced Research Center, or CEDAR, at the Knight Cancer Institute. Dr. Bertazzoni leads a multidisciplinary research group working on various aspects of biomaterials and tissue engineering, and his work has encompassed various aspects of microscale technologies and bioprinting for tissue regeneration, nanoscale structural and mechanical properties of mineralized tissues, and different aspects in the fields of organs on a chip. It's our pleasure to have him today to tell us about his work. And I neglected to introduce the title for Dr. Casper, so I'll do that here. Current and future applications of 3D printing in orthodontics, restorative and regenerative dentistry.
All right. Thank you, Dan, for the introduction, and thank you for the invitation to present here. I think that Kurt made my life a lot easier in giving you a beautiful introduction to different aspects of 3D printing in dentistry. And I wanted to build on that and essentially bring a little bit more of the perspective in restorative and regenerative dentistry, which is more what I've been involved for the past few years. So I'm going to go right into the gist of it so we don't spend too much time on the details. So I wanted to start first by talking about some of the reasons why there's been such a hype around the technology of 3D printing, which we basically see everywhere. But you know, it's unclear exactly why that can be considered a revolution in the industrialized world. So I brought 10 different topics here, 10 different aspects that essentially summarize why there's such a hype. And I'll briefly go through them. So first of all, the fact that there are no geometric constraints to different parts that you can build. So you have some examples here with very complex internal structures, which you can't really do with other fabrication methods. The idea of the complexity versus cost, the fact that you can print increasing levels of complexity, but that doesn't actually make your part more expensive. That is something that is quite unique to 3D printing. The improvements in fabrication time. So for instance, you have the example here of several parts that have been printed essentially at a single print run. And if you compare that to typically what would happen in the lab, right, the technicians doing one by one, taking several days for each one of these parts. The fact that there is very little material waste, the fact that the technology is fully automated with robotic precision for everything that you do. So now again, as I mentioned earlier, if you compare that to the traditional ways of doing manufacturing, especially in the dental field for orthodontics and restorative parts, you know, only in that slide you have several reasons to understand why that represents such a shift in technology. If we build from that, 5 other reasons, right? It's a very portable technology nowadays. You can have it essentially at chair side, very easy to use. You don't even need to know CAD anymore to be able to build 3-dimensional parts in the computer. You can actually just scan, as Kurt just showed. You can scan a part, send it to the printer, and off you go. It's a truly scalable technology. You can 3D print tiny little parts. You can go all the way to printing houses, which is already being done in several parts of the world. The technology is essentially compatible with everything that we know as far as the digital workflow in dentistry. Although there are some kinks here and there, but essentially, you know, it fits right into this idea of digital dentistry that we've been involved with and essentially pioneer in the field of medicine and dentistry several years ago. And ultimately, it's a technology that is amendable to multiple types of materials. So you can 3D print metals, you can 3D print ceramics, plastics, you can 3D print cells, you can do bioprinting, as we're going to show a little bit here. So altogether, you know, briefly showing 10 different reasons for why this technology is unique and why it represents so much for the field of dentistry, medicine, and several other things out there. So just going into the details of the aspects of 3D printing that are more relevant to dentistry. And I brought 2 different aspects here that are not your typical extrusion printing. One is the stereolithography that Kurt just presented nicely, and the way essentially that works. And basically, you know, you start with a CAD file, 2-dimensional CAD file, and essentially the stereolithography or the light laser stereolithography will raster the surface of this photopolymer, and in the process of exposing these monomers to light, you can photocross link these individual parts, and essentially as you do that layer by layer, you give rise to a 3-dimensional construct, right? That's different from another type of light 3D printing, which we call digital light processing, in that you're not essentially rastering the surface. In this case, what the printer does is it creates digital photomasks, which is what you see here, where the part that is white is exposed to light, the part that is black basically is being blocked from light. And as these digital photomasks essentially are creating the 3-dimensional part that you see here for this example of a bicuspid valve that was 3D printed in this very nice paper that was published in Science in 2019. So why is that relevant? Because modern restorative dentistry specifically relies heavily on photopolymers. So if we're talking about, photopolymers and why that's relevant, I think that there is a lot of interest for this idea of 3D printing different things that relate to dentistry, and you can go to several aspects that relate to different orthodontic appliances, as we just saw, different prosthodontic appliances, and especially a lot of different types of models and so on. But for a restorative clinician, and as you see for a regenerative dentist, there are aspects that are more relevant to intraoral restorative procedures that are not necessarily as explored at the moment, and that's the direction that we've been pushing towards. So these are examples of 3D printing systems that are actually available in the market for 3D printing of restorative dental materials that can be essentially cemented in the patient, and the patients can use, and are readily available not just for models or orthodontic appliances, but for actual restorative procedures specifically. So this is by 3D Systems, NextDent. They also make dental resins that are specific for 3D printing, and VisionTech has a whole portfolio of printers. Stratasys is one of the pioneers, DWS, Formlabs, which most of you are familiar with. It's a low-cost 3D printer system. So I'm going to give you a few examples of what I'm referring to as far as 3D printing with restorative composites or materials that can be used directly in the mouth. So this is a 3D printable resin that is commercialized by NextDent, and it's indicated for crown and bridge long-term provisional. And these are some examples that I actually pulled from the website, from VisionTech's website, for the different types of applications. And what is interesting here is that these resins, these composites, are essentially very similar to your flowable composites that we use in the clinic today. And the good thing about that is that, a lot of the technologies that we are familiar with and that we have used for a number of years are essentially the same ones that are being translated into this new format of actually creating an entire two-dimensional restoration before you cement it in the patient, hopefully chair-side, to speed up the process of the whole manufacturing that typically would happen in the lab. So these are Dymatech resin blends, low viscosity. They have a very similar filler content to what we see in other composites of low viscosity, of course. The filler size is also very similar. And in this particular case, we use an Ember Autodesk 3D printer. This is actually an open source 3D printer that you can basically open up and hack into if you want. It costs less than $10,000. It's a DOP type system. The resolution is down to 40 microns in XY, and the lowest Z thickness that you can print with is 20 micrometers. So, it's quite a precise system. So the questions that we started asking were, now we have this new method, and much like what you saw in the previous slides, right? You start wondering what the different types of printing formats would actually result in. So how do you print? Horizontal, vertical, diagonal? What is better? More layers, less layers? How accurate it is? And we just saw a very nice example of how that affects the accuracy of the printed parts. So we started with these 3D printed bars with different angulations here for the printing process, and looked at the mechanical properties of these different printed structures. And much to our surprise, like Kurt mentioned earlier, we found that if you're printing with these bars horizontally, right, 90 or vertically 90 degrees, there's very little influence for the layer thickness on the mechanical properties. But as we go down to a horizontal printing process, we start seeing a very significant effect for the number of layers that are being printed. And we believe that that has to do with the sort of like the delamination or the weaknesses between sort of like individual layers that are being built. We also found something similar as far as the accuracy. Basically, the same thing that we saw earlier. If you go down to a 0 degree in printing, you increase the inaccuracy of the printing process. Now, the next question that we asked was, if we're printing these provisional materials and comparing with what is currently used in the clinic, right? Is there a benefit to printing in comparison to what we know and have used for many years, or is it at least comparable? And it turns out that in terms of flexural modulus, we actually have pretty comparable data, slightly higher in terms of flexural modulus here for the printed composites, if they are printed with these pre-optimized conditions of 90 degrees, 100 micrometers per layer. And the interesting thing is that one of the reasons why we believe that that's happening is because when we map the degree of conversion for the different layers of the printed parts relative to these non-printed materials that are used clinically, either jet or integrity, we basically see that there is a very, very even and homogeneous conversion throughout the entire printed structure versus the jet or the integrity, where you end up having a much more sort of like uneven and heterogeneous degree of conversion throughout the entire system, and that leads to the better performance. So I wanted to jump into a different format, and that's the question that I get the most when I'm presenting about these printed, polymers and plastic-based materials. What about ceramics, right? That's essentially what a lot of the clinicians are interested, especially the prosthodontists. And the truth is that at the moment, we can actually 3D print high-density ceramics that have a very very high mechanical properties and comparable to what we find out there for conventionally treated ceramics. So this is a technology that we've partnered up to use with Lithos Ceramics. It's a company from Switzerland. And the process that they use actually takes advantage of the same principle of using light to essentially photocure things in place, but they actually use a combination of ceramics and a photopolymer, which is what you see here in the top left corner. So essentially this combination of a solvent, ceramic, and a photopolymer allows the material to be photocross linked at a precise three-dimensional structure. Then after that, you would remove the solvent and then essentially remove the polymer through a proprietary process that they have developed. And this is essentially what we're looking at in terms of the complexities of the different parts that you can print for ceramic or pre-ceramic at this stage. So essentially you're printing with this combination of the ceramic and the photopolymer here. This is right after printing. And then after you do the sintering process, there will be about a 25% shrinkage, which is expected, but that results in about 99% density for different types of ceramics. So I wanted to use that to compare with what you would typically find in an isopressed ceramic, and you can see that both in terms of mechanical properties for bending strength for stabilized zirconia and also alumina, you end up getting very high mechanical properties that are comparable to what you typically get for an isopressed material. The most important thing I think that you can appreciate from the SEM images is really the density of these materials, which is quite comparable and very high. And that's essentially what makes this type of printing process different from other ceramic printing that you've seen out there for extrusion, especially, where you don't get quite as high density for the majority of the methods that are available. So now I want to shift gears a little bit and give you an example of how these 3D printed ceramics can be used for different applications, and I'll use this as a hook to switch to the more regenerative applications of 3D printing. So here, what we did was we 3D printed these ceramic pieces that using the method that I just explained previously in partnership with Lithos. And we actually 3D printed these ceramics using a beta TCP material, which is known for its use in regenerative applications for bone tissue engineering. So what we did here was we 3D printed these different micro cages in the form of these Lego-like modular scaffolds. The idea here was that we could print this material that is pretty rigid, but it could be stacked, just like you would stack different Lego parts, right? And this allows for a variety of different combinations of sizes and geometries and shapes that essentially go as far as imagination can take you. Those are pretty small, but still large enough that they can be stacked manually in the operating room. And the fact that they are hollow, they have this sort of like cage-like structure. This allows us to load different types of microparticles inside, and that gives rise to a very unique benefit, which is the ability of actually putting different composition of particles in different locations within these micro cages. And then after you basically stack them together, then this becomes a larger three-dimensional piece where you actually can have instructive components in different regions of your Lego, essentially. So here we compare essentially microparticles that are distributed in a specific format across this 3D printed structure after stacking with your conventional, essentially conventional composite scaffold material. So this is essentially the same 3D printed BTA-TCP material, but just completely covered with a type of hydrogel. And the idea here is to achieve the spatial temporal control over the biologic process that would happen after implantation. So we first did some in vitro testing to see if we could truly guide cells to different locations. So what you see here is basically the 3D printed scaffolds with the sort of like organized particles in different regions on the top left-hand side in comparison to the regular composite. And you can appreciate from the graph on the top right side is basically showing that if you have growth factors of different composition in different regions of your scaffold, you can really guide cells very precisely to different regions. Whereas if you simply mix the same growth factors in the hydrogel, essentially cells just go sort of like everywhere. We also compared how far essentially cells go three-dimensionally inside of these 3D printed micro cages. And what you can see here again is that in these microparticle loaded gels, cells can basically go inside of these cages and populate the entire sort of like the depth of that structure. Whereas with the conventional composite material, cells will form a monolayer. So you're seeing cells, and now as you go deeper into the cage, then cells disappear. And that's because cells have a much harder time to penetrate that structure, inside of the 3D printed cage. So that uses a combination of printing processes to give rise to these outcomes. And then after we implant these, we were pleasantly surprised to see that we could actually vascularize the core of these 3D printed BTA-TCP Lego-like scaffolds in about 7 days, and actually increase both the cell number and the number of vessels, by about 3 times in comparison to your typical composite, right? So by guiding cells and putting growth factors at the right place at the right time, we can actually facilitate vascularization of the core of these pretty large, chunky scaffolds, which is one of the big challenges in regenerative medicine and regenerative dentistry, especially for bone regeneration at the moment. So the idea here is to use these Legos, for different types of applications, spinal fusion, ridge augmentation, and so on and so forth. And that's what we're pursuing right now. So the last example of how we've been using these 3D printing processes that I wanted to give you is going more into this idea of bioprinting, right, as opposed to conventional 3D printing. And I think that the key difference here, and this is quite a controversial definition, is that when you're doing 3D printing applied to medicine, essentially you're using inks that don't have any living biological material, right? Living cells, essentially. I think that that's the main difference that sets bioprinting apart from conventional 3D printing. And as I said, this definition varies depending on who you ask, but our interpretation is that when you start printing with living cells, the whole printing process changes drastically. And the reason for that is because all of your parameters that you would use to control the printing process, temperature, pH, all of your sintering, the high temperature lasers and light that you use to do, like metal printing and so on and so forth, all that goes down the drain. You basically have a very, very confined set of parameters that you can use to make sure that the cells are alive and tolerating the process. So I'll give you some examples of how we use the same technologies, the exact same printers, in fact, that you've seen previously, but now for doing high throughput bioprinting of cell-loaded injectable microgels. So in this example, we use the same printer that we used for the composite printing that you saw at the beginning of the presentation. We loaded the vat of this 3D printer with metaculated gelatin hydrogel encapsulated with mesenchymal stem cells. We exposed these to essentially that digital photomasking process, and that allows us to 3D print a variety of different types of shapes and sizes, and that happens fairly quickly. So this is how the process looks like. Essentially what we're doing here is we're creating a library of microgels. Each one of these microgels has about 500 micrometers in size. We'll print them in quadruplicate, and this library allows us to control the stiffness of these hydrogels. So basically, the ones that get exposed to light for longer are stiffer. The ones that get exposed to light for shorter are softer. This is what the gradient will look like. You can see here on the top right side of the slide. So we go from a soft stiffness to a high stiffness. This translates into the ability of these gels to absorb a rhodamine dye. And this is the actual measurement on the bottom right-hand side for the actual stiffness of these materials. So it goes basically from very low all the way to about 45 kilopascals. And the idea here is that we can, create these materials that are very small, small enough to be injected, and we can print them in very high quantities very quickly. So we can actually make about 2,500 microgels in a question of 2 to 3 minutes, or even less, actually, depending on the printing process and what you want. We can even do it in 30 seconds. And what is interesting about these materials is that when we print them, they end up having these supramolecular gel characteristics. That means that they tend to aggregate naturally because of the hydrogen bonding effect of these very small materials, and they actually hold close together even without any confinements, even though they're individual materials. And they also have these sort of like self-healing abilities. So for instance, if you take a razor and you cut these gel-like material here and separate them, after approximation, they will basically regain their shape, and there's no specific chemistry here, no special effect other than the fact that these microgels are printed very small and they are highly hydrated, so they have both self-healing and supramolecular capacity just because of the nature of the printing process and the shape that they have. The other advantage of this system is that now we can 3D print these cell-laden hydrogels. So in this case, we printed these gels loaded with Huvix endothelial cells, right, and mesenchymal stem cells in different shapes. We can culture them for 3 to 4 days in highly optimized conditions in the lab. Let, for instance, a vasculature form, which is what you see here on day 4, the formation of vascular capillaries inside individual microgels. And then we can take these microgels, for instance, and implant these in a root canal model, which is something that we've been doing for a long time and we're familiar with. And what we can see is that these engineered vessels go on to anastomose with the host vasculature and actually form perfusible functional vessels in about less than a month. In about 3 weeks, you actually see red blood cells going through these engineered vessels in vivo. Whereas if we compare with a standard injectable gel that you simply load into the root canal, then there's a lot less tissue formation inside of the tooth. So this is just one example of what we've achieved with this printing process. So just to conclude then, the 3D printing aspects in restorative and regenerative dentistry, I think we're going through this shift now that the question is, what is better, addition or subtraction? I think that there is a lot of reasons to believe that additive processes have a lot of benefits, but the track record of subtractive processes is still pretty much unbeatable. For the next, I think, decade, we're still gonna slowly migrate, I suppose, to this idea of additive manufacturing, and that's gonna depend on a lot of data and information on the true benefits of these new processes. 3D printing is rapidly being introduced into dentistry, and it's, I think, absolutely here to stay. And the reasons for that, I think, goes back to the two first slides that I presented, right? Faster turnaround times for impression to production, less waste, higher precision, higher reproducibility, essentially I think it all comes down to money, right? I mean, you can basically get your productivity much higher at a much shorter time with much better precision. As far as the bioprinting goes, what is the big deal about the printing? I think that is the idea of, as we showed a little bit, the ability of creating these complex heterotypic tissues with patient-specific dimensions and geometries and shapes and whatnot, potentially using patients' own cells and so on and so forth. So in a nutshell, for a very short amount of time, I think that this summarizes a little bit all of this transition from the restorative processes all the way up to the regenerative dentistry with a few specific examples. And if you're interested in seeing a little bit more about some of these specifics that we talked about here, there's a couple of publications that our group put together in the past few years where we discuss a little bit of the 3D bioprinting for regenerative aspects, but also the restorative as far as composites and ceramics that we published last year in a couple of review papers. So if you're interested, you can have a look at that, or just shoot me an email. And with that, I just wanted to acknowledge some people. I saw that we have some of my co-authors here in the audience. Lucas from New York is here. Thanks for helping this work. And I'll gladly address any questions that you may have together with Kurt after this. Thank you so much.
Super. Thanks so much. What a great second talk, and some great science to hear from both of you. We really appreciate it. Kurt's back. Fantastic. So I'll encourage folks who've been listening to submit questions. We'll pass those on to the speakers. I'll start with one that was posted for Kurt. Basic question of if you could refresh what the liquid is that's used for the SLA method. This was a question from one of our attendees.
Sure, thanks, Dan. The materials that we used in the studies that I presented were all commercially available resins from the manufacturer of the 3D printed. The printer, the exact composition is proprietary and isn't disclosed, but very similar to some of the materials that Luis was discussing early in his talk. It's a mix of methacrylated oligomers primarily.
Yeah, thanks. And I think there's a complementary question for Luis about if you could suggest a few biocompatible resins used for 3D printing. So I guess maybe if you can just comment more broadly, what's the status of biocompatibility for these materials?
Yeah, this is a great question. I think that there's a wide range, right? You have essentially biocompatible resins that have very similar composition to the composites that we use in the clinic nowadays, which is basically what I alluded to in one of my slides. The difference is that the FDA and some other agencies across the world are still regulating these as if they were essentially different products, and that is because the process of manufacturing ends up affecting the biocompatibility of the material, even though the composition is the same. I don't know if I make myself clear, but essentially, right, the fact that you're not licuring a composite with the way that we have optimized and tested and used clinically for the past several years, that makes it that makes that same material slightly different because of everything that we showed. Right now that we start using the same composition of material but printing at different angulations, different thicknesses, and so on, that can end up leading to residual methacrylates, which can be cytotoxic and so on. So I think that the FDA specifically is being a little bit careful as far as how they regulate that for intraoral use. And right now, the biocompatible resins that are commercially available, they are still limited to long-term provisionals, which is a little bit dubious, but around like a year or so max. But you have a very wide range of biocompatibility, going from all the way up, essentially composite resin composition, very similar, down to more cytotoxic materials that can be used maybe for a day or two in the mouth. These are like simpler, sort of like PMMA resins, right? Which theoretically could be used for much longer, but we know that they tend to be slightly more cytotoxic, to really cytotoxic materials or not biocompatible materials that can be printed for models and other things outside of the clinic. So, you know, I think the good thing is that now there are commercially available materials that you can just go to the website and you can choose, and it makes our lives a lot easier. There's not a whole lot of research that needs to happen to identify that.
It's very interesting. It's you know, you hope to see kind of new materials coming out, and I was particularly interested in your solvent ceramic kind of mixture. I have to think that as you're trying to make structures from that, there's a change in viscosity that changes the entire workflow, I would expect, unless the particles are just so small that they you know, have less of that viscosity change. But I'm curious personally if you could kind of speak to that, how that impacts the workflow.
Yeah, the viscosity is the major roadblock, right? If the viscosity is too high, especially for these light-based processes, you basically can't really print. So, you know, in that case, you have to be within a very low range of viscosity to enable that type of, you know, light-based lithography printing. And I think that it's relevant to say that lithos specifically, they found a very specific composition that works really well to allow you to reach very high density after the sintering process while still maintaining the viscosity very low to enable the printing process. And I think that that's really where you find key differences between other types of ceramic printing processes out there and lithos proprietary process. And full disclosure, I have nothing, you know, to do with lithos or anything. I don't get anything from them. Much the opposite. I actually pay them to print stuff for us. But I think that, you know, the technology that they've developed several years ago enables for high precision of printing, high density, very high mechanical properties. And I think that that's going to find its way into the dental market fairly quickly, and it's probably going to change a whole lot of things for what we do, especially in the prosthodontics field.
Yeah, I think you'd expect so. I think this is this next question is a good one for both of you. How can we control bacteria in the oral cavity using bioprinted, 3D printed biomaterials?
Kurt, you want to go first?
I'm happy to. That's a really interesting question, and I've seen folks in the literature starting to engage in that space, and that's something that we're interested in but haven't really explored in depth. Some folks have looked at 3D printing of appliances that can release in a controlled fashion different pharmaceutical agents, antibiotics or other agents that could knock down certain bacterial species or strains or groups to try and tip the oral flora in a particular direction. So I think we're in the nascent stages of seeing that emerge as a big topic in the literature.
And Kurt, I imagine for your thoughts about cleft lip and cleft palate, that must be something that comes to mind. If you've got these tissues that are still somewhat exposed, one wants to be more mindful of that bacterial exposure and such.
That's absolutely right, especially in the cleft palate population, because you have not only the oral flora, but also flora from the nasal cavity, which increases the complexity of the bacterial load that's present, of course.
Mm-hmm. And Luis, I didn't mean to cut you off. Any thoughts on the bacterial question?
Yeah, I think the only thing that I would add is that the same, I mean, there's been a lot of research on that for the polymers in general, right? In dentistry, it's a hot topic, I think, at the moment. And I think that that's the beauty of this transition of existing, right, monomers that can be printed. Virtually, you can translate a lot of the existing technologies onto a printing aspect. The only difference is that instead of being manually made, they begin to be printed. So as Kurt said, I've seen also, slow release antibiotics in printed materials and everything. But there's a lot of correlation between what has been done previously without printers and how to adapt these existing technologies into printed parts.
Yeah. Let's see, we have just a couple more specific questions, but I do want to be mindful of time. Kurt, in particular, there's a question regarding, I might be kind of pitching a softball to you because I think you've done this, but did you scan your models to do a comparison of accuracy to the STL file, or did you use CMM data, is the question.
We scanned the models to do the comparison to the input files that were used for printing, and we applied metrology software to compare those surfaces. But we also have some studies that I didn't report today where we've engaged in linear measures by hand of dentally relevant landmarks to kind of confirm what we're finding with metrology.
Mm-hmm. Super. Well, it is 1 o'clock Central Time. I do want to be mindful. I think that's where we were supposed to be reaching our ending time, and you were both excellent in not going over in your own talk, so we appreciate that. Thank you to both of you for sharing your research with us today.
Thank you
Thanks,
very much, Dave, for moderating. Thank you, Louise, for your presentation, and thank you, Kurt, for your presentation. I do have a couple of parting announcements before we go. If I'm able to get my screen to share correctly, and I'm not. Sorry about that. Bear with me for just a moment. Okay. So the Hawaii Symposium was to have happened in December. We've changed the dates on that to the end of July in 2021. We'll have a call for abstracts published there shortly, and the abstracts will be due kind of late winter, so sometime around January or February of 21 for the Hawaii meeting, and that's a joint meeting with the Japanese Society for Biomaterials. Our call for proposals for the Chicago meeting. Chicago meeting will be in April of 21, and that call for proposals has gone out. The call for ideas deadline was at the end of June, and the program committee evaluated those and requested full proposals. And that deadline is August 16th. So if you submitted an idea, you should have received a request for your proposal, and please submit that by August 16th. And last but not least, because this is open to everyone, if you've not yet joined the Society for Biomaterials, please do so. And if you have, thank you very much for your support, and please encourage a colleague to join. And with that, I'll thank again Dan and Luis and Kurt, and thank you all very much for your time today, and have a great day.